Hello everyone, my name is James and I'm a physical therapist in Canada, and today we're going to go over some of the relevant factors of Parkinson's disease that you should know as a physical therapist. We will briefly go over what Parkinson's disease is, its epidemiology and etiology, and signs and symptoms that you should be aware of if you are working with an individual living with Parkinson's disease. On the next video, we will talk more of the tools and treatment programs that you may consider when you're working with these individuals. So let's get started. So first of all, Parkinson's disease was first described by James Parkinson in 1817 on his essay on the shaking palsy. It is the second most prevalent neurodegenerative condition. First, if you have to guess, is Alzheimer's disease. What it is a complex group of movement disorders with specific motor clinical manifestations. So, complex movement disorder. On today's lesson, we will focus mostly on the idiopathic Parkinson's disease. So let me just write that down. I'm going to shorten Parkinson's disease as PD there. And the reason why we're focusing on idiopathic Parkinson's disease is approximately 80 to 90% of the reported cases are idiopathic, meaning there's no known cause, so unknown cause. The causes are poorly understood. Some studies suggest environmental factors, while others are suggesting genetic factors. Parkinson's disease is a chronic, progressive disease of the central nervous system. And the diagnosis is based on the motor symptoms, which we will discuss later, and the medication response. So now that you have a brief idea of what Parkinson's disease consists of, we'll go over the epidemiology quickly. So epidemiology. So the usual onset occurs between 50 to 79 years of age, and around 5 to 10% develop symptoms before 40 years. And its prevalence increases with age. And sadly, men have 1.5 times higher prevalence of Parkinson's disease. To just briefly talk about its consequences, it is a costly disease, as usually people living with Parkinson's disease develop or have secondary comorbidities due to the symptoms that they have, which cause them to be inactive. And I'll talk more about it later on as well. Now we're just going to talk about the etiology of it. So just to brush up your mind on neuroanatomy, it is characterized by a degenerative loss of dopaminergic cells in the substantia nigra pars compacta, which is located in the basal ganglia. Basal ganglia is involved in almost all types of movements in humans. It is responsible for postural corrections, and is responsible for alternating movements, spontaneously occurring movements, as well as planning and motivation in movements as well. So if the substantia nigra pars compacta has lower amount of dopaminergic cells, which produce neurotransmitters that are important in doing these activities, then in return, people who suffer with Parkinson's disease are gonna have difficulty moving, planning, as well as alternating movements and posture control. Just to give you an idea, I'm just gonna draw something over here. If we say that this is the basal ganglia over here, normal brain would have little bits of dopaminergic cells that are visible, while the Parkinson brain would have few or nothing at all over here. So I'm just going to write normal. And how this was discovered is that post-mortem samples of individuals who lived with Parkinson's disease were taken, and what they did was they cut cross sections and examined, and that's what they found. We're not going to go into too much detail right now, but this seems to be similar in Alzheimer's disease as well. So we're going to talk about one of the most important parts, which is clinical presentation. So I'm just going to give you a really good acronym that you can use to remember what you should look for in individuals who live with Parkinson's disease. It's called TRAP. So T stands for tremor, R stands for rigidity, A stands for akinesia, or sometimes you can use bradykinesia, and P stands for postural instability. If I just go into more detail about these symptoms, around 70 to 100% experience tremor, and it is usually the initial symptom as well. And it starts unilateral, which means it's going to begin with one side of the body. And this occurs at rest, occurs when they're stressed, and it does interfere with sometimes with sleep as well. Rigidity, around 89 to 99% experience this as a symptom, and it also starts unilaterally. And some of the examples that you will notice include cogwheel, we call it, and lead pipe. Akinesia and bradykinesia means that the individuals will experience either lack of movement or slow movement. So you will see this in around 89 to 99%. And basically they're going to have difficulty with movement initiation. So movement initiation, this is difficult. And sometimes you will see freezing or hesitation of movement. And as well, because they have difficulty moving things around, they also experience this on their face, so they have decreased facial expression as well. So the last bit, postural instability. A lot of individuals who have this disease tend to have their center of gravity forward. Because they're stooped over, their postures in that way. And also because their center of gravity is forward, they have abnormal postural responses. And decreased motor activity. So as you can see, the quality of life, it's going to decrease due to the symptoms, which in turn causes more inactivity, and this can cause other secondary comorbidities. And this is pretty prevalent in a lot of hospitals where people are kept in inpatient unit for a long time, because people initially come in because of falls from Parkinson's disease, and they can't move as much due to their symptoms, and they develop other diseases secondary to what happened as a result of Parkinson's. So it is important as physical therapists to kind of look over a broad perspective, have an idea of what the classification systems are, how to use it, as well as develop a treatment program that is appropriate for each individual, so that we can maximize their potential to get better or manage their symptoms. So what I'll do next session is go over some of the things that I just talked about, which include severity description using Hone and Yar, as well as Unified Parkinson's Disease Rating Scale. As well, I'll go over some of the treatment programs that you could or you may use, and other things that you should know about. Thanks for watching this video, and I'll see you next time.